Photographs, videos, or other accounts or descriptions, whether data, textual, or visual, of all or any part of this program may be used only for personal non-commercial uses. All other reproductions, transmission, or use in whole or in part in any form or medium without the express written permission of the City of Eagan is strictly prohibited. You may not use this program or any portion thereof for political campaigning, recruiting votes, or soliciting support for legislative or other initiatives.
Welcome to the Dakota County Regional Chamber of Commerce Healthcare Forum. My name is Phil Stahlberger. I'll be moderating this morning, and I am the incoming chair of the board as of October 1. Pleasure to have everybody here today. The Dakota County Regional Chamber of Commerce is committed to building a strong regional business community. We proudly serve the cities of Eagan, Farmington, Lilydale, Mendota Heights, Rosemont, Sunfish Lake, and West St. Paul. Leading the way to make the Dakota County area the best possible place to grow your business, we advocate and educate on important business issues such as healthcare reform, which is why we're here today. I first of all want to thank Argosy University for hosting the event today. Thank you very much for this great space. I also want to thank ETV for their investment of time in taping this event. Also thank you to our panelists for taking the time out of their day to educate us about this important topic. Just a quick background. On March 23rd, 2010, the most sweeping overhaul of America's healthcare system was signed into law. Not since the invention of Medicaid and Medicare in 1965 had the United States seen such a sweeping change in healthcare. The federal law called the Affordable Care Act, ACA, Obamacare, and many other things created a stir among more than just the healthcare industry, but created a stir among the entire country and businesses across the United States. It truly touches every man, woman, child in America. The 950-page bill was signed into law with the promise that it would provide health insurance to more Americans and would also reduce healthcare costs. Ever more difficult than passing this bill in Congress was the fact that after this law was passed, it was plopped down on every state capitol steps in America. Now, just as Congress did, they continue to do, as we know, we could debate various aspects of the law with rhetoric and political accusations. However, today, we're going to take the time to actually talk about what is the law, the facts behind the law, and how this impacts various businesses in Dakota County and you as residents and businesses as well. We can't cover every aspect of the law, but with the help of state lawmakers, health insurers, hospitals, brokers, and benefit managers, we know that our expert panel today will help educate us on what the law is. With that, I'm going to introduce our panelists. We're going to hold questions until the very end, so they're going to be up here presenting. First off is Representative Lori Halverson. Lori is currently the state representative for Eagan's District 51B. She was elected in 2012 and serves as the vice chair of the House Elections Committee and as a committee member on the Commerce and Consumer Protection Committee, Health and Human Services Finance. And in her previous professional life, Lori worked at Blue Cross Blue Shield of Minnesota, leading public affairs and civic engagement efforts. Next to Lori is Lynn Nelson. Lynn Nelson is Director of Legislative Affairs and Chief Lobbyist at Blue Cross Blue Shield of Minnesota. She promotes the organization's policy positions and initiatives at the state and federal level. She has been at Blue Cross for over 6 years, and prior to joining Blue Cross, she was at the Minnesota Department of Health in the Commissioner's Office as Director of Planning and Special Projects. Next to Lynn is Tom Hoffman. Tom is the Vice President and General Manager at Prime Therapeutics. As the leader of Prime Therapeutics' individual market initiatives, Tom has overall responsibility for strategic preparedness and client support for Prime's reform-based exchange offerings. Tom's experience also includes consulting roles focused on process re-engineering and strategy.
We're out of order. We don't.
Sorry.
Throw me off base already.
Just testing you.
Yeah. Our next presenter after Tom is going to be Joan Cole at the very end. Joan is an account executive at Gallagher Benefit Services. Joan guides businesses and human resources professionals in the process of developing employee benefit programs that bring the best value to their organization at the most cost-effective pricing. Her expertise includes all aspects of strategic planning, market research, and implementation, and has been in the industry since 1985. Since 1997, Joan has specialized in employee benefits and is licensed in life, accident, and health insurance. Our final panelist and presenter is Beth Crable. Beth is the Chief Executive Officer at Fairview Ridges Hospital. Beth is responsible for ensuring the delivery of consistent, high-quality care and services to patients in a compassionate, safe environment. She directs strategic and technical planning efforts that both support the mission and strategic direction of Fairview Health Services. Beth has over 25 years of healthcare leadership experience and is a registered nurse with a clinical background in acute care, behavioral health, and home care and hospice. So we have an amazing expert panel this morning, so we're very pleased to have them here. Let's give them a round of applause. So our first panelist will be Representative Lori Halverson. Lori will come up here and give her presentation. Again, we'll keep questions until the very end.
Well, thank you, Phil. I have to make sure my water's ready here. Because I'm going to talk fast. We have a lot to cover. Thanks a lot for having me today, and thanks for being here and spending your morning talking about one of my favorite topics, which is healthcare policy. As Phil mentioned, we have seen sweeping changes go into effect at the federal level. Frankly, in Minnesota, they're less sweeping than they are in other parts of the country because of Minnesota's healthcare leadership. And so today, what I would like to do is provide us an overview of how we got to where we are in healthcare in Minnesota. Answer those questions of how come employers are so heavily involved in providing healthcare in Minnesota, and what are we going to do about healthcare costs, and what is the future going to look like? So. My hope is that when we're done, we have a good background with which to build on the future and go into details on some of the issues that all of you are going to be facing as healthcare reform implementation moves forward. So how did we get here? Before 1920, hospitalization, hospital care actually tended to be a place where people very often just went to die. It wasn't a place where you went to get healed. It wasn't a place where you stayed and got well. Very often the indigent went to die. And hospitals started looking for ways to change what they were offering and to offer more care and to be seen as a place where people could get care. And so Baylor University came up with this idea that they were going to work with a group of public school teachers and have them pay 50 cents a month, and they were going to, in return, offer them care at their hospitals. This plan took off and eventually became what we know as Blue Cross. Blue Cross programs like this with hospitals started spreading to every state in the country. And by World War II, we had factory owners who were looking for ways to encourage more employees to come to their businesses. And so they were looking for ways to offer additional compensation and compete for employees, and healthcare looked like the place to do it. And so they started offering these types of hospital healthcare plans. And again, back when healthcare plans started, we were talking about hospitalization. In 1943, the federal government actually helped solidify this by ruling that healthcare benefits are a tax-free benefit for employees. So unlike your payroll, the healthcare that you're offering your employees were tax-free. And then the federal government went on to codify that further in 1954. And so by 1954, the tax advantages were such that employment and healthcare were tied for the very reason that employers could offer greater compensation to their employees and compete for the best and the brightest. So you can see the impact that that had. About 9% of the population was in health plans in 1940. By 1953, that grew to 63% of the population. And then by the mid-60s, if you had a good job, you probably had health care that went along with that good job, hospitalization care. And then the folks that fell through the cracks, so the poorest of the poor, the retiree population, and people with disabilities got coverage through programs through the Social Security Act expansions of Medicare, Medicaid, and Social Security disability insurance. So that's kind of the private-public partnership that we see today. Federal reforms continued. ERISA, and I won't go into a ton of detail on this, but it impacts you all because it differentiates the way that our state government can regulate self-insured health plans. Small employers tend to be fully insured, and so small employers will be more greatly impacted by state healthcare taxes, by state regulations. And then in 1996, the federal government passed HIPAA. And I know that we all hear about HIPAA once a year at our healthcare provider when they hand us that sheet and say, here, sign this so you've seen our privacy laws or privacy policies. And privacy is one of the P's in that acronym HIPAA. The other one I think that's particularly important for this group is the portability. And so in 1996, the federal government passed a law where our health insurance became, if we were in a group plan, became portable, if you will. So if you moved from employer to employer and you stayed in a group plan, you stayed insured, in spite of the fact that with your previous employer you might have gotten a diagnosis of diabetes, or you might have had a back injury. You didn't have to go through the underwriting process again and risk being uninsured or being uninsurable. So that's that was a significant reform. Minnesota was certainly in the Healthcare Reform Act early on and passed some pretty remarkable and nation-leading legislation. So in 1973, we saw the Health Maintenance Act, which made all of our HMOs that operate in Minnesota had to be nonprofit. That law continues today. We are the only state in the nation that requires that. The outcome of that is that our healthcare dollars that we spend, our premium dollars that we're spending, go to healthcare costs as opposed to going to shareholder dividends. That's probably the easiest way to talk about that. In 1976, the Minnesota legislature also created what we call MSHA, because you can't have enough acronyms in this business, the Minnesota Comprehensive Health Association. And that was the state's high-risk pool. So the ACA, a lot of people were up in arms because they are having concerns about the fact that there was a high-risk pool that was created when the ACA passed. But the fact is Minnesota passed a high-risk pool back in 1976. That high-risk pool, because everybody is going to have access to the marketplace, is actually going to close in 2014. But that was extremely innovative for Minnesotans, and it had a big impact on the private marketplace, because what was happening is the sickest of the sick, the people with chronic diseases, the people who maybe weren't sick anymore but had had an issue like a back injury, had taken medication for depression, had had a child with asthma, in the individual market really weren't insurable, because the risk pool was such that the sickest of the sick made everybody else have to pay more in the individual market. And so having the high risk pool where people who could not get insured in the individual market actually had a significant impact on the private marketplace. Minnesota Care was passed in 1992, another significant increase. 1992 was a time where nationally there was a huge healthcare reform conversation, and Minnesota really stepped up with, I think, a plan that was innovative, that closed the gap, that was very effective at closing the uninsured gap. Again, this is at a time where we were riding down from a small recession, not like the one we just saw. And so the issue of the uninsured was big in Minnesota, and it was having a significant cost on the public sector, but also on the private sector, because uncompensated care costs us all money. Minnesota Care is also significant in that it was bipartisan. It had a broad group of stakeholders at the table making this plan. And I think it's evidenced in the fact that Minnesota Care is still going strong today, that it was a well-planned and well thought out reform. In 1993, Minnesota went on to codify medical loss ratio, which a lot of folks, again, have heard about in the ACA. So almost 20 years after Minnesota passed it, the federal government put in the ACA, with the help of Senator Franken, a similar provision that essentially our premium dollars have to go to health care. So 80 to 85% of our premium dollars that we pay as ratepayers are required by federal law now to go to health care. So we're talking about putting pressure on plans to squeeze administrative costs and make sure that we're paying for health care and not having the majority of the money going into salaries, administration, inefficiencies, those types of things. So what are the outcomes of these reforms that we've seen in Minnesota over the years? We saw a dramatic increase in uncompensated care, and that was proven to have a direct impact on the costs that hospitals were having to charge, essentially the rest of us, charge the private market, because hospitals were the plan of last resort, if you will. And if you were really sick and you were hospitalized, or if you were brought into the hospital unconscious, you received care. But somebody ends up paying for that care. And if you're not insured, it ends up getting shifted onto the private marketplace. And we did have a point in time after Minnesota Care passed, and no one's going to believe this, but Lynn can back me up. Premiums in Minnesota declined because of the advancements that we made in covering people. So I think that that's some really good evidence for the policies that Minnesota put in place were actually really good for the private market. And these were good times. We had an uninsured rate in Minnesota as low as 5%. And about 2/3 of those people in that 5% were eligible for health care in some way, shape, or form. We hear a lot about those young immortals who think that they don't need to buy health care. That was the biggest group of this population. And then there's also people who just for one reason or another couldn't navigate or didn't navigate the complex state programs. Now we've got this great balancing act of health care. Employers are entrenched in the system. We have created a system of public-private partnerships here in Minnesota, and individual consumers are also part of this, increasingly more and more part of this balancing act. And then you've got your federal government, which is federal government, state government, county governments. All we've woven together to take care of regulation, to provide payment for some of the folks they cover and administer programs. So it's a balancing act. I'd like to think it could look like that. I'd argue it looks like this. It's precarious. Some of what we balance doesn't necessarily make a lot of sense today, but I think going back and looking how we built this brick by brick, it does make some sense. And so when we make changes to this careful balancing act, it has an impact and a ripple effect throughout the system. So now what are we looking at? We saw this economic downturn of where small employers, such as yourself, we're having trouble keeping up with the rising cost of health care for a number of reasons. Certainly because of the economic downturn, but also because healthcare costs have been rising in the last decade at 2 to 3 times the rate of inflation. That's going to have a significant impact on what we pay in premiums, and there's no sign of that abating at this point. So healthcare costs are a huge issue. Additionally, our uninsured rate began to go up because of the economic downturn. More and more people found themselves unemployed. Some employers found themselves unable to provide health insurance as they had in the past. But Minnesota is still way ahead of the nation. We're at about an 8.7% uninsured rate currently, compared to the national average of about 15.4%. So we've got almost half the uninsured rate as the rest of the country. Why is that important? Because the uninsured cost our state money. And it doesn't just cost public dollars. It's not just costing us tax dollars, it actually costs us premium dollars. And I think it's important that we continue to understand that. And we can illustrate that by taking a peek at Texas. Texas consistently is the worst in the nation for their insured rate. They're 25% right now. They've been as high as 29% uninsured in Texas. Interestingly enough, Texas spends a greater percentage of their gross domestic product on health care than we do in Minnesota. In spite of the fact that we have made these investments in public programs, we've expanded public programs, we've worked, our government has worked with the private sector to expand coverage, and the impact has been that we actually get better results, healthier population, and we have lower spending. Minnesota, as I've said, is ahead of the nation. We were at the business partnership dinner last night, and I think the theme was Minnesota is great, so I'll just continue it this morning. So in spite of the fact that healthcare, that the healthcare system that we're all facing is that precarious balancing act, we're doing it better than a lot of the rest of the country, and I think it's important that we know that. So a lot of the components of the Affordable Health Care Act, when I saw that bill, when it passed, I was flipping through it, and people always say that legislators don't read bills, but I do. So I wasn't even a candidate, and I wasn't even elected when I was reading this bill, so I really have it bad. But I was looking through, and there was things in there that were quite familiar because we passed these reforms in Minnesota. In 2008, Minnesota determined that children can stay on their parents' health insurance until age 26. So that was a way for Minnesota, and now the federal government is attacking this problem of one of the most volatile uninsured populations. And those are those young people who are just starting out in their first jobs and aren't able to access insurance. And that's important because when those young folks get sick, they get real sick. They break legs, and they, in my husband's case, he had cancer when he was 19 and he was uninsured. So insurance in this population is really important. Additionally, Minnesota expanded preventative care coverage as a requirement, but also as services that were offered, so more outreach for preventative cancer screenings and trying to make sure that we have a healthier population. As I said, 76, we passed a high-risk pool. That was old news. And interestingly enough, these reforms were passed during GOP administrations. And I think that that's important to note because Minnesota's history of healthcare reform has been about bipartisanship. It's been about getting to the goal as opposed to being heavy on ideological arguments. And in 2013, we did pass a number of pieces of legislation, including expanding Medicaid, which is part of the ACA. The federal government gave us the option as states to expand our Medicaid to populations, essentially raising the income levels where you're eligible for Medicaid. And we matched that by also improving Minnesota Care. So we worked to close those gaps of income for folks that might be in the private marketplace, might be really volatile. And these populations, I think it's important to note, are not static populations. These populations are moving in and out of private and public programs constantly. And so Minnesota, the legislature continued to work to close that gap. And when you think about the vulnerable in our healthcare system, it's those folks that are just outside the ability to access public programs that are really, really vulnerable. You're one paycheck away, you're one job away, you're one illness away from not being able to cover your health care. And we did pass MNsure, the Minnesota Healthcare Exchange, which we all know. We're live on October 1st. I did not ultimately support the final package that got passed, but it's not because I didn't support a Minnesota-based exchange. Again, Minnesota has done healthcare reform impressively over the decades. My concern was a lot of the conversation was about elbowing the private market out, and my experience and my research on healthcare policy has shown me that having our private market have skin in the game has made a big difference in terms of maintaining our public programs and helping to control costs. So I wanted to see more of that, and I didn't get to. But I continue to work with the author of the bill, and we talk frequently about the exchange rollout. So it's something I'm still engaged in. We did cut the Health and Human Services budget by $50 million. We balanced that by protecting the vulnerable. Our nursing homes, long-term care providers had seen dramatic and draconian cuts over the past several decades, and it's had big impacts, again, not just on the public services that are being offered, but on private marketplaces. If you look around the state, and this had bipartisan support again, there's many small communities where your nursing home is your big employer in the community. And they were finding that they did not have the resources to compete for employees with Menards across the street. And I would argue that you want the best and the brightest taking care of your grandparents and ensuring that we are taking care of the most vulnerable in our communities. And so we did provide a significant increase to both nursing homes and long-term care providers. We also expanded access to mental health services for adults and children. This is going to be an issue that we're going to continue to talk about. So you'll see things that are putting more pressure on our healthcare system, like an aging population, like access to mental health services, are going to, places, we often took care of mental health issues after we deregulated mental health in the criminal justice system. And so we're moving that back into a healthcare system so that we are actually providing care and hopefully staving off long-term costs in inappropriate care settings. So what's our future going to look like? We're going to have to build it together. So the past 20 years, we've focused a lot on access because we knew that that was driving down costs. But we haven't gotten a handle on the way that costs are rising now. And sadly, success in controlling healthcare costs is talking about slowing the rate of growth as opposed to trying to level anything off. And it's not necessarily because of problems within the system. Sorry, my timer went off. But you have to think about the fact that we have access to miracle cures that we never had before. And if somebody has cancer and you're offered $1 million chemo treatment, are you going to say, that's a burden on the system. I don't think I can take that, doc. And employers, but one of the places we have taken steps in controlling costs has been with the health of our populations. Population health used to be driven dramatically by the government. When you think about vaccines and the way that we used to control public health, employers have taken on a big role in the public health area as well by promoting wellness. Why? Because it has a direct impact on the premium costs that we're paying. And so programs that help employees quit smoking, programs that are helping employees go for walks on their lunch breaks instead of to McDonald's every single day, have an impact. And there are great stories. General Mills has great case studies on work that they did. They kind of started this trend early on because they had a population of salespeople who were on the road who had tremendous risk and tremendous costs of heart disease because of the lifestyle that they were living. And so decades ago, General Mills started to work on employee wellness, and the proof is in the pudding because it does have a cost payoff. Again, we're balancing it out though with what healthcare actually costs. So it's not a silver bullet. And what I have found, and when we talk about these programs, is that healthcare users are really willing participants. And I hope that you find that in your employee populations as well. I'm amazed at how many people are willing to step up and say, yeah, I've got some responsibility in this. Yes, I've got skin in the game as a healthcare consumer, and I'm going to think about where I get my care. If I take my kid to the ER for earache, is that the best use of healthcare resources and my healthcare dollars? If I smoke, if I'm overweight, am I doing the best that I can to help control my healthcare dollars? And the users have been willing participants. These reforms and partnerships have put Minnesota ahead of the game in the nation, and I think in Minnesota we're in a good position to lead if we come together as stakeholders in the healthcare system. And interestingly enough, it's kind of one of the only policy areas that all of us are in there together, And so with the ACA, payment reform is going to be part of the conversation moving forward. The ACA is looking at ways to promote more, because they've got big purchasing power through Medicare. So they're looking at ways to promote more effective outcomes. You got to think about the way our healthcare system has been built up, that we have been talking about a fee-for-service system. The more care you give, the more money you make as a provider, and that's changing. And there's been different attempts to reform that over the years, but I think that you're going to see more conversations about how we pay for healthcare going forward and what our outcomes actually are. This is going to take some changing in the way we think in all sectors of the healthcare economy, including the fact that we used to talk about health insurance because health care was an unexpected cost. You might end up in the hospital someday. That's how it started out. Now we want to use our health care, and in fact, there's some people who say, I want to get my money's worth out of my premiums. I want to be sure I get everything I can out of it. I've never heard anybody say that about homeowners insurance. And so the other thing that we need to think about, I believe, is that the health care, we talk a lot about the marketplace. You saw the balancing act that we have. It's not a true marketplace. It's not, we can't as consumers go and shop for health care in most cases. And by that I mean going to your doctor's office and saying, I have to have a knee replacement, and what does that cost me? Has anybody asked that question? Yeah, what answer do you get?
We don't know.
It depends. They don't know. It depends. And that's not, there's a lot of pressure for consumers to do that kind of shopping, and consumers hit nothing but roadblocks, so we need to do that better. And the other thing is very often when you're sick, it's the hardest time in the world to be a self-advocate. And so we need to make sure the system is in place that we can have the best choices and the best cost options available to us up front. In the current system, again, we put more emphasis on volume than we do on coordinating care and outcomes. We need to change that. And then finally, there are great cost disparities. I'm sure you guys have seen, there's been more and more studies done, cost disparities from provider to provider to provider. You can go to a provider and look at one procedure and it might be $5,000, and you go down the street and they might charge $13,000 for their procedure, and it has a lot to do with overhead, the way that they charge, the way that they pay their employees, their doctors, et cetera, different billing processes. So there is a lot of that mystery, I think, makes it tough. So we can talk a little bit more. I think Lynn will probably be able to cover some of this too, but Minnesota has also been working on talking about how we reform payment. I would say that that's a mountain that we have a long ways to climb. There have been some reforms that have been passed, the outcomes of which I think are still up in the air. And I'll tell you, I think it's in large part because we're renaming old ideas, like capitation, we're calling baskets of care. There's reasons why those things have not worked in the past, and we need to get to the root of those reasons why those haven't worked. So I'm going to work hard in the next legislative session. I'm working with Representative Huntley, who chairs Health and Human Services Finance, to put together a healthcare cost study group in the legislature, because we need to understand what's driving our healthcare costs in our system. We can't continue to face 2 and 3 times growth in the rate of healthcare costs and at the same time look at the population that we're going to be caring for in the next few years. So that'll be an action step I'll be taking. And I'll be looking at ways that we maintain access, because that's important. We support innovation and we improve outcomes for patients. And with that, I'm going to turn it over to Lynn, who's going to be able to deep dive on the health insurance part of it.
Good morning. Thank you, Lori. And thank you to the Chamber for 1, having coffee, and 2, for putting me second so I could drink my coffee while Lori was speaking. I'm not really a morning person, so you'll have to bear with me this morning as I go through this. You know, Lori did a great job of doing a very nice overview, because this is a really complicated subject. And there's not a lot of legislators that understand it. I think we have 3 in the room right now that really do understand healthcare, so it's really nice to have that backdrop and the presentation you did. So I really appreciate you going through that and giving a little bit of an overview, because it's complicated. There are a lot of acronyms, and there are a lot of things that we need to understand. We've been at Blue Cross, we've been going around the state and speaking with agents in about the last week, and just trying to give them an idea of what's happening in 6 days. October 1st is just 6 days away. We all thank you very much. October 1st is just 6 days away. And you know, back in 2010, when the ACA passed, we thought, wow, we have a lot of time, and all of a sudden, 6 days, and none of us are getting a lot of sleep in the industry. I think everybody is feeling a little anxiety and going forward and trying to make sure everything works and it's seamless for our members. Blue Cross has 2.7 million members, and some of them will definitely be impacted by this, but we want to make sure things are seamless for our members and make sure that everybody has covered, and we want more people insured after all of this and not less. So thank you for the help with this. I don't want to mess it up again, so just arrow forward. All right. As I said, Blue Cross has a long history of supporting health insurance or health reform. We want to cover more of the uninsured. We want to improve access. And we were very supportive of a Minnesota-based insurance exchange. And regardless of whether or not we agree with the totality of the bill as it passed, we are implementing it. And we are making sure, again, that it's implemented successfully and that everybody has a seamless approach to this. And we're working with the state very closely. Lori did a really good job, but reform will really only be successful when we get to the underlying healthcare costs. We did health insurance reform now, and now we need to look at the underlying healthcare costs to make sure that we decrease that trend and that trend that's moving forward. And the impacts of reform are going to be different for each and every one of you. And we can't say that everybody is going to have this much of an increase or everybody is going to have this much of a decrease. It's really going to impact each and every employee, employer, individual differently. And I think that's what makes it so complicated and hard to explain, because you have to go to each individual and kind of say, what's your situation, what's your income level, and all these different questions to see how it impacts them. Now, how is health insurance changing? With the ACA passing, there's really 6 main components of how health insurance is changing. One, we're covering the uninsured, and Lori talked about that a little bit, improving access and Medicaid expansion and things like that. We're covering pre-existing conditions, and I'm just bucketing these. They're much more detailed than this, but these are the big buckets. Requiring broader benefits in the form of an essential health benefit package. In Minnesota, we have 64 mandates, so those will be in the essential health benefit package. And there'll be broader benefits for some customers that didn't have those benefits previously. We're limiting premium differences to various customers, providing financial assistance in the way of subsidies. And the way we do that, and how do we do that, when somebody has to pay for this. So there is a tax on health insurance at the federal level and at the state level. And there's also some medical device taxes and some other taxes that come into play. But this is expensive, both for covering the uninsured and providing financial subsidies, getting exchanges up and running, so there has to be a way to pay for it, and the way that everybody's paying for that is through some increased taxes at the state and federal level. Now, you heard a little bit about the things that we had in Minnesota, which were so great. In 2010, we did start to implement some of this, but Minnesota already had some of the ACA in place. And so we didn't have a lot of changes to make. A lot of them were more of the administrative side of it, more regulation side of it. So they didn't have a huge impact on premiums. Some of these are here, the up to age 26. We already had to 25. We only had to go a little ways, so we didn't have very far to go. But the consumers didn't really see a large impact on premiums, even though we at the health insurers did see a lot of changes on how we were being regulated and different things that we were going forward. Now move forward to now and the things that will be implemented on 1/1/2014. And there are a lot of things for access, guaranteed issue and renewability, no pre-existing conditions, single risk pool, the subsidies and financial impact that we'll have, financial subsidies we'll have for individuals, rating restrictions, federal rate review, essential health benefits, as I said, a richer benefit package for some that may not have had some of those benefits in the past, and grandfathered plans. So this does have an impact on premiums. And you will see, consumers will see more of an impact than they did from the things that went into place immediately in 2010. And also, it will have some impact, I think, on provider capacity, and Beth may talk about that a little bit, and where there may be shortages because of increasing access and having more people insured. You may have some impact on that. Now this is going to be a little bit difficult to read, but these are some of the taxes that are in place for the fully insured market, which is a small group and individuals. And you can see that there was a new premium tax that supported the Minnesota Exchange. There was a new federal tax, the federal insurer tax that will go into place in 2014. And these all impact premium rates because we have to build them into the premium. This is for the self-insured market. So if you're with a large employer that's self-insured, maybe 3M or Target, you have a much smaller tax base that's paying this. And the small group and individual market is getting smaller all the time, and it's really about 25% of the entire market in Minnesota, maybe a little bit less. It's shrinking and shrinking and shrinking. So there's more taxes on that small group and individual market than the self-insured market, and that's kind of what I wanted to lay out here. So what do these changes mean? As I said, most people with coverage from a large employer are really not going to see a lot of changes in 2014, and I'll talk about that a little bit further, a little bit later. Significant changes for those in the individual market and the small employers, as I said before. Guaranteed access and broader insurance benefits. New coverage, benefits, rules, and taxes will increase costs because we have to build those in. And the financial assistance, which will be great for some people, again, we have to pay for that somehow. So what is the reform environment? And you're probably hearing a lot about this from the national level. There's gonna be a government shutdown unless they defund the ACA or Obamacare. I don't think that realistically is going to happen, but you'll hear a lot about it in the next 6 days. And we can't really, you're not going to repeal the ACA. It's going to happen. I think they're on vote number 42 for repeal, and it hasn't happened yet. So there may be some tweaks as we go along to see what's being implemented, what's working, what's not working, and we'll have to look at that at the federal level after 1/1/2014 and see what we can do. So the MNsure and the Obama administration are really focusing on those young invincibles, but a lot of those are on their parents' coverage to age 26. So we have to get those in. The MNsure board is actually meeting, and they met on Friday. They're meeting almost, I think, every 2 weeks. Sometimes they're adding a couple more meetings. They've had a couple hiccups recently, but we expected that. It's a huge undertaking to move to the health insurance exchange, and it's a very short period of time. So when you look at the operational environment, like I said, Blue Cross has really been working hard on IT components for MNsure and trying to make sure that they talk to each other, that everything is seamless. But I have to say that right now the operational environment is a little scarier than the political environment. No offense to any elected officials in the room, but because we are really down to the wire. Like I said, we're 6 days away. We're just starting to test and see if everything works. So when you hear things in the news that the system crashed or it's not working, I think the Target system crashed when they put a new product on the line, right? So I can anticipate that there'll be a lot of people that'll be trying to get this covered, trying to see what MNsure is all about, that are actually impacted by it. And then there'll be a lot of people that are just the looky-loos, that want to go and see what it's all about. And so the system might be to capacity, and you're gonna see some problems probably. The good news is open enrollment is from October 1st to March 31st. So there's a long period of time, and I think I've even heard some rumblings that they're urging people maybe not to go on October 1st and to wait a little bit. I can't remember, what day is October 1st? Is it Tuesday? Yeah, it's not great. It'll probably be at capacity. I talked a little bit about the individual and small group market. And I know this is a really busy slide, but what I want to show you is who is really impacted by the changes in the ACA. And 76% of Minnesotans really aren't impacted because either they're self-insured or they're in Medicaid or they're in Medicare. So that's a pretty large constituency that's not necessarily impacted, but they think they are. So there's a lot of questions and concerns. We have about 3% in the Minnesota Care Healthy Contribution, or Minnesota Comprehensive Health Association that was talked about earlier. Now the Minnesota Comprehensive Health Association will not be taking any new enrollees as of 1/1/2014, and then they will be phasing out, going away 1/1/2015. But some of those members will continue to stay in that risk pool, the high risk pool that we've had forever. That's one of the most successful, is the most successful in the nation. No insurance, about 9%, as you heard before. Purchase myself is an individual, 5%, and then small companies are about 7%. So this down here, the smaller part of the pie chart are really people that will be impacted by the ACA and the changes that are coming forward on 1/1/2014. It's a little smaller than probably people think, because I think we're getting a lot of questions, and first thing I ask them is, how do you get your health insurance? And that can guide you about where you take them to the next level. If it's yes, it's all those algorithms or if-then statements, and that's why I took algebra in high school and college, right? There's a lot of that going on, and it all makes sense now. In the Minnesota Exchange MNsure, I think you may have seen a couple weeks ago that rates were released by the Department of Commerce, and we're happy to see that the rates were some of the lowest in the country of those that have released rates for the exchange. And so that makes it a little confusing. It's not compared to what you have now, it's compared to other states and what they've released. But it's good news. It's a good news story for Minnesota, and trying to keep those rates low so that we, again, cover the uninsured that aren't insured now. There's carrier choice in all counties for the commercial market, at least 2 or 3. There's rate variation between areas, and I won't get into that, but there's different geographic rating areas, and the southeast part of Minnesota is significantly higher than some other parts of the state. As averages don't tell a story, and what that really means is everybody is going to be impacted a little bit differently. And so you really have to go in, find a professional, find an agent, find a broker, find a tax person that can help you through this and help you understand the implications of ACA and how it will impact you. Oops. I had a nice little state of Minnesota up there, but this is participation on MNsure. There's 141 different products that are on the Minnesota-based exchange. 5 carriers are in the individual exchange, including Blue Cross. There's no national partners that are in the exchange, which is interesting. 3 carriers on the small group, and again, we have some of the lowest rates in the country so far. There'll be more rates that will be released, and so we'll have to see, but so far so good. And I just put this up here to show you that, it goes back to 2012 on this timeline for getting ready for open enrollment, which starts in 6 days. But we started long before that. And there's different parts that we have to get through, and timeline and IT components, and IT is really the biggest lift. If anybody has been through an IT change, it doesn't happen overnight. It takes a long time. We're doing all of this in a very condensed time frame. MNsure is doing it in a condensed time frame. We're doing it in a condensed time frame. We need everything to work together. We have some contingency plans. We're already moving to some of those contingency plans. And we have contingency plans for contingency plans, even if we have to go to manual. We don't want to do that, because who wants to go back to a manual process at this point in time? We do have that. So I just put that up there to show you there's a lot of different elements that have gone into the implementation and getting ready for open enrollment, which starts on, and coverage starting on 1/1. So really 3 things that we really need to look at is, manage expectations for Minnesotans and consumers about, one, who is impacted by the ACA, and how do you manage that, and that it will be messy, and things might not go right. It might not go right at the state level. It might not go right at the federal level. It might not go right at your plan level. But everybody is working really hard to make sure that Minnesotans are covered. And I think we all have your best interest in mind, my competitors as well. Premium cost mitigation and regulatory fixes. I think, again, there's not going to be a delay. I think this will all happen on October 1st, at least for Minnesota, which is good that we have a Minnesota-based exchange. But there could be tweaks and there could be fixes, but it'll take a little bit. And I think we're lucky in Minnesota that, we have some states that are surrounding us that we can look at as a comparison. Wisconsin has a federal-based exchange. Colorado has a little different organized exchange. So we can look at those and see what's working well, what's not working well, and take those into consideration. It's probably going to take a little bit. We might not be able to get to it next session. But then again, there might be some things that we really need to change legislatively that will help with consumers and the impact on them. And really, innovation, not government, should drive cost and quality. The market still needs to have that innovation, and that will drive competition, and that will drive cost and quality. And we need to remember that and not let government micromanage all the great things we've already done in Minnesota as far as healthcare reform that didn't really necessarily take legislation at the federal level to do that. And we've done a lot of things, collaborating with providers. I know that we have, I talked to a lot of my counterparts across the nation, and they're like, wow, you talk to your providers? You have that kind of relationship with the hospitals? And we really do, and I think we all have the same goal. We don't have the same way to get there all the time. And again, as I started, we had some unsustainable healthcare costs. We still do, and everybody knows that. And so we went to health insurance reform. We're in health insurance reform. We've done that. And really, to be successful now, we have to look at the underlying healthcare costs and get at that and to bend the cost curve to make sure there's a downward trend on premiums. So with that, I'm going to turn it over to Tom Hoffman from Prime.
Yes, when something's going wrong, right? So thank you, Lynn. I'm Tom Hoffman from Prime Therapeutics. We are a pharmacy benefit manager, also known as a PBM, and we are the pharmacy benefit inside your health insurance. So most of you probably have no idea, nor do you need to know, that the pharmacy benefit inside your health plan is administered separately and by a separate company. So I will talk a little bit about Prime, a little bit about what a PBM is, a little bit about the Affordable Care Act and the exchanges. Lynn and Lori have done a great job covering that already. And then I'll talk a little bit about what it means for a small business person, like I think many of you are, and what opportunities are coming that are new in 2014 based on the rollout of MNsure and the exchanges in general. So just starting with Prime's purpose statement, you can see it there. I won't read it to you, but really the reason we're here is to help members of our health plan partners get access to the medicine they need. And more medicine is becoming a more important part of the healthcare picture. And so our job is to make sure that that medicine is easily accessible and at affordable rates. And again, I'll talk a little bit more about what that means. But we all at Prime, all 2,500 of us have to memorize this purpose statement, and we really do try to live it every day at work. So a little bit about us. I won't read all the stats there. We are a for-profit company owned by 13 Blue Cross Blue Shield plans that are all not for profit. We do have some Blue Cross Blue Shield clients that are not owners, so 13 owners, 21 clients, and again, we are the pharmacy benefit inside your health insurance. We cover 23 million members. We manage $15 billion in annual drug spend, and you can see some of the other stats there. A little bit about our Minnesota presence. We do have about 2,000 employees in Minnesota. We have a big Bloomington location and a big Eagan location, so many of those employees are here in Dakota County, and many of the employees that work both in Bloomington and here in Eagan are Dakota County residents. So we cover 1.5 million Minnesotans, and really our headquarters and our home base is here in Minnesota. So we really do consider Minnesota home, and we have a very vested interest in MNsure and the state exchange going well. So a little bit about the Affordable Care Act. And again, Lori and Lynn did a great job covering. There's really two primary tenets. It's accessibility and affordability. And I think accessibility breaks down into a lot of different things. One of them is just simplifying the process. And part of what the exchange will accomplish is sort of standardize what you're looking at on health plans. And so when you're shopping on the exchange, you'll be able to easily compare health plans. And I think once you're able to kind of break it down at a simple level like that, it will help with the accessibility. This will mean that millions of people will funnel into the individual market. So there's 25 million uninsured Americans today, or 50 million, I think, uninsured Americans today. We don't have as many of those in Minnesota, but as they funnel into the individual market, that will help sort of clean up some of the cost drivers and other things that we're trying to manage. Affordability is another one I talked about. There are some provisions within the Affordable Care Act which will make health insurance more affordable. So preventive coverage, dollar caps on out-of-pocket maximum, the elimination of lifetime maximums. There's also subsidies that are available both to buy insurance and use insurance. So if you think about, say, a $1,000 deductible, you might be able to scrape together enough money to buy insurance. But if Johnny breaks his arm and it's subject to a $1,000 deductible, that may not be a cost that you can cover. And so there's subsidies that are available not only to buy insurance, but to use the insurance. And we'll talk a little bit about that as well. Lynn covered some of the key dates on her timeline. I'll just recap them real quick again. Here, March 23rd, 2010 is when the Affordable Care Act was passed. October 1st of 2013, so 6 days away, that's when open enrollment starts. And so that's when people can actually start buying insurance for 2014. And that will really be, in many ways, the start of the Affordable Care Act. And then January 1st is when it all goes live. So that's when people who buy on the exchanges can start using their insurance. And then March 31st is when open enrollment ends. So that will really be the last opportunity to buy insurance for 2014. And then as we get to the end of the year, there will be another open enrollment period that starts. And so that's kind of the way it works in a nutshell. Just a little bit more about the exchange. Again, it creates a more organized marketplace. So the idea is that you have multiple carriers competing in one place. They're standardizing their offerings, so you don't have to be a PhD to try to figure out what it is you're looking at. And it will simplify the process. There's buying power in that the exchange will negotiate rates on your behalf. So instead of being an individual out there trying to figure it all out, the exchange will do much of that for you, and it will, again, simplify the process and make the options more affordable to you. It will establish common rules, and will just provide some standard information that, again, will make it easier to understand. The state exchange here in Minnesota is called MNsure, and one of the things that's really nice about Minnesota is that we are one of only 13, is it 13 or 17 states? 17 states that will be building our own exchange. And so we really can make it specific to what's important to Minnesotans. It will be customized, so again, things that are important to Minnesotans and are unique to our state will be incorporated into the exchange. All right. So qualified health plans. So again, one of the things the exchange accomplishes is it standardizes the plans that are available to be purchased. So it does that through a qualification process. Blue Cross and other carriers competing on the exchange have to submit their plan designs. The states will review it and say, does it meet all the criteria to be qualified to be sold on the exchange? And one of those key criteria is essential health benefits. In other words, what is the minimal coverage that will be available in those plans being sold on the exchange? And you can see the list there. It's a pretty comprehensive list. The one that we are most interested in at Prime is prescription drugs. So there is a minimum level of prescription drug coverage that will be required in every health plan sold on MNsure. And that covers, kind of all your basic drugs. There's some requirements around the number of drugs available in each class and category. You don't really need to know those details. I think all you really need to know is that there is comprehensive prescription drug coverage in every health plan sold on the Minnesota exchange, and really any state exchange. And you can look at all the other coverage there, and again, feel comfortable that any plan you buy in a state exchange is really going to be comprehensive coverage. So a little bit about pharmacy coverage or prescription drug coverage. It's not something that people think about often, but it is a very prominent component of any health plan. And we like to say that it is as important as a health benefit, if not more important. And some of these stats will tell you why we like to think that. The prescription drug benefit is used typically as much as 11 times more often than the drug benefit, or than the medical benefit. So if you think of a standard health plan, how many times you go to the doctor each year, how many times you pick up a drug at CVS or Walgreens, on average that happens, the drug coverage happens 11 times more often than the medical coverage. And typically the pharmacy benefit is the first benefit utilized in the plan year. So we're very aware at Prime that our members' first experience and our health plan partners' members' first experience with the Minnesota Exchange will likely be via a pharmacy benefit. Many people like to go to CVS or Walgreens on the first of the year, pick up their prescription, and that's got to work. And those benefits need to be ready. The people at the retail counter at Walgreens, they're not going to take time to figure out why the benefit's not working. We know that it's got to be ready on day one, and so we're very aware of that. And you can see there that on average 13 prescriptions per year per member in the health plan, so that's pretty significant. Some of the things we're doing at Prime is we're setting up a pre-enrollment website, primehelps.com, and so a lot of good information there around the Minnesota State Exchange and really all of the state exchanges around the country. There's a lot of detail around what pharmacy benefits will look like in the health plans that we service, what you need to know about pharmacy benefits, what are the things that you should be thinking about as you shop for drugs, and it will help you if you are in one of the states for which we have a health plan partner. It will help you look at very specific information around the drug benefit available in the various plans that we support. So is my drug covered? Is my pharmacy in the network? That sort of detail will be available on primehelps.com. One of the things that we're thinking about, and really the entire pharmacy industry is thinking about, is the cost trend on specialty drugs. Okay, so I think everyone is aware of Lipitor and sort of your standard prescription drugs, that sort of thing. But one of the things that's happening more significantly now is the emergence of specialty drugs. So these are very high-cost drugs, things like chemotherapy or growth hormone or fertility, things that can cost in the hundreds of thousands of dollars. And so you can see there that the volume versus cost equation is, it's flipped upside down when you talk about specialty drugs. Again, a single prescription of specialty drugs can be thousands of dollars. And typically these are drugs that are being used in very acute and very significant medical situations. And so this is one of the drivers of cost, but it's also a very important component of people's health care. And so we, as a pharmacy benefit manager, are working with our industry partners and others, manufacturers, to figure out what can we do to make these drugs available but also make them affordable. So this will be one of the things that we're working on in coming years as healthcare reform evolves. And just a little bit more around specialty drugs. You can see the stat there in the header. By 2018, 50% of all drug costs will be specialty drugs. So really this is one of the things that we'll be working on to help maintain these costs but still make these drugs accessible. All right, so just a little bit about pharmacy plan design, and then I'll talk a little bit more about what it means for someone trying to buy insurance as a small business person. So I talked about essential health benefits and what prescription drugs will mean there. So there is a standard minimum set of coverage for a prescription drug. So the question becomes, what will differentiate health plans and specifically prescription drug coverage on the exchange? And the answer is, it's not that the list of drugs covered will change, it's that the tiering associated with those drugs will change. So I'm not going to go into the detail here and sort of bore you and put you to sleep like Lori's poor husband, but all I'll mention there is if you look across the horizontal axis there across the top, those are the various tiers that some of our research people have found across the industry. So we did some industry benchmarking, and you can see the various tiers there. That means that a generic first-tier drug may have a different copay than a second-tier drug. A specialty tier may have a higher again, cost share, copay, or co-insurance than some of the other tiers. And so that's the way that pharmacy benefits will be differentiated on the exchange. And if you're someone who has maintenance meds or using a lot of prescription drugs, that's the sort of thing you need to be paying attention to when you're buying insurance on the exchange. And we can talk more about that when we get into Q&A. So, from a small business owner perspective, just a couple things to think about as you're contemplating buying insurance on the exchange. The first one is a fundamental question. Is health benefits part of what you want to do for your employees as part of your overall business strategy? I think everyone sort of would like to be able to afford coverage for their employees. It becomes a question of, can you do it within the industry that you operate in? Is it part of your business strategy to be competitive? Is it something you need from an employee retention perspective? All of those things that I'm sure many of you have thought about previously. So that's a first fundamental question. If you do make the decision to think about covering your employees, then here's a couple other things that you should think about. Starting in 2015, coverage will be required for businesses with 50 or more full-time employees. So you've maybe heard the term employer mandate. This is the rule. Starting in 2015, if you have 50 or more full-time employees, you will be required to offer insurance to them. And if you don't, there will be tax penalties. Full-time employees defined as someone with 30 hours a week or more on average that they're working. So if that sort of defines your business, it's something that you need to be preparing for, because in 2015 it will become the law. And then the last thing here is something, I was just in a meeting last week with some of the people from the Massachusetts connector, so Romney Care. So they're really sort of the ones that started exchanges. And they also, in their state, offered a small business healthcare tax credit. And it's horribly underutilized. This is free money available from the state if you meet the criteria and are offering coverage to your employees. So some of the criteria I've got listed here: if you have fewer than 25 full-time employees, your employees make an average of $50,000 or less, and you pay at least 50% of their premium, you qualify for a healthcare tax credit. And again, it's free money. It can pay up to half your cost of health coverage for your employees. So I would encourage you, if you meet some of these criteria, talk to a tax person or just get on the Insure website and investigate, because this is free money that's on the table and very few small businesses actually use it, and it's just sitting there waiting to be used. And again, I've got some of the detail up there if you want to see it. And then finally, how will a small business person buy insurance on the exchange for their employees? There's something called SHOP. It's the Small Business Health Options Program. And it really has sort of the same objectives as the individual exchange. It provides purchasing power for small businesses. It provides some of the administration of the health plan. So it really makes you, the small business, makes it easy for you, the small business person, to just define, here's how much money I want to contribute to my employees' health insurance, and the exchange will take it from there. There's IDs and passwords that you give to your employees. They'll log on, they'll see what plans are available to them, they'll see what the costs are, they'll see how much you are contributing as their boss, and then they'll be able to buy the insurance straight from there. MNsure will bill you, the small business owner, and so it really becomes quite simple. And it's an easy way, it's an affordable way for you to offer insurance to your employees. I'm not here on behalf of MNsure to sell you on it. I really have no interest, but I look at what's available out there, and I just think it's such a great option, and it's so affordable given the tax credits. It's just a shame that it's not utilized more often. All right, and so that's all I have. Next up is Joan Cole from Gallagher.
This is an incredible time in my career in 17 years. It's probably the most stressful, anxiety-ridden, busy time, and I'm sure it is for all of you too. Those in the large group market have probably already gone through the last year with the payer play and done the math and discovered where you are. But for small groups, we really are just now ramping up. into a lot of changes, a lot of questions. What should we do? What are other people doing? What are other businesses doing? And so when I was at the Blue Cross conference yesterday, the president, what he said I thought really made sense, and we have to really think about that this is really a work in progress, both in the private market and in the exchange. There are going to be changes. It's going to fluctuate on what's happening, and there are going to be errors, but we just have to really be patient. And those of you small group people, I really hope that you are patient with your brokers in the next couple months, because information that we really don't even have yet is what we're waiting for. People are anxious about what the rates are going to be in January, and we have no information on that yet. And so, we're really stressed that we can't provide what our clients are looking for yet, and it may be a little later than normal in some of the aspects of what we are getting, and I'll probably allude to that. The things we know that are going to be required, and this is going to be old news to you now, but of course the waiting period, you can't have over a 90-day waiting period, and you need to talk to your broker if you do have over a 90-day waiting period, because that's going to have to be changed for plan years on or after January 1st. Also, I'm sure you've been distributing the summary of benefits and coverage, that nice little 6-page summary, and that has to be distributed 30 days before your renewal date. We know that there's not going to be any auditing the first year, but a lot of my groups have already started having their employees sign off that they have received this. And it's not a bad idea starting in January. We don't really know if a DOL audit would discover that you haven't had people, how you're going to say or how you're going to communicate that you distributed that. So it might be a good idea to do that, and it's not that difficult. Some of the other changes in the small group market, we know, I'm sure you have heard, if you're in the small group market, that there's not going to be any rate tables any longer. There's going to be what's called, you're going to hear, a community rate, and it's basically a single risk pool. And so for some small employers, it's going to be really good news because they might be at the highest end of the rates, and they probably will be seeing a rate reduction, although as time goes on, I'm seeing that with the taxes and such, it might not be as good a news as I might have relayed to them earlier in the year. But for those that are at the lower end of the rate table, obviously we're really nervous about the kind of increases that they're going to be seeing, because it could be as much as 25 to 30%, and we're going to be dealing with that. We have heard that they are able to have smoker and non-smoker rates. We have not heard from any carriers other than Blue Cross who has said that they will not have smoker non-smoker rates, which is really good news. And I'm assuming that other carriers are going to follow along that line. It would be terribly difficult to administer that. There will be a change in the rates for children, and now that they can keep their children on the plan until age 26. However, starting in January with plan years on or after January, children who are 21 to 25 will no longer be considered in the small group market in that 1 child, 2 children, 3+ children band. And so that's been really helpful for a lot of families who have 3 children and they have a college person. Well, those children in that age rate, 21 to 25, will actually be charged the adult rate. So for the 20 to 25 age band, they will be charged a separate rate for that. So for a lot of people with kids in college, they're going to want to look at, maybe the exchange as an option, or plans under the college plan. And for those that have kids that aren't working, the exchange is probably going to be a really good option for them. In the small group market, it's just kind of an update of, you're probably, if you have that Cadillac plan, which a lot of nonprofits, there are still quite a few that have that upper echelon plan with 100% coverage. You're probably not going to see that exact coverage for next year. There will still be a really good plan offered, but we're thinking that we're not going to see that. At least we're not seeing that with Blue Cross. A couple of things that we did see in this essential benefits, things that are going to need to be covered, but we really hadn't heard any kind of news or anything being talked about. And those are the vision and dental. Well, we know that the health plans are going to have vision coverage, and what we have learned is that that will cover one pair of glasses or contact lenses for children under 18. However, the cost of those is going to be subject to your plan design. So if you have co-insurance or a deductible, you're going to have to meet that deductible first. So it may make sense and it may work for some people who have met the deductible or who don't have a deductible, but just to know it's not necessarily going to be free. The thing that we're the most concerned about is the pediatric dental that is going to be required, and this is a little more complex. And I've really just learned in the last couple of days through talking with Delta Dental, for example, that none of their plans comply with this regulation, and actually none of the other carriers do either. Health Partners, it's possible, but we haven't been able to get a for sure answer on that. So what that means is Delta Dental has come out with 2 plans that comply with the pediatric dental as a standalone. And there's a low option and there's a high option. And the low option pricing is right around like $23. So our concern in this is, how does that work? I mean, we really don't want to add $23 onto a family cost if you already have a dental plan. And so this is really yet to be discovered. I mean, I haven't been able to get any answers for you today, but just know that your agents are going to be working hard to try to figure out what the best plan is depending on who you have for a carrier and whether you can maybe change your family designation to single plus one and then add the pediatric dental. So this is probably our biggest concern now, is that we don't have the information that we want concerning this particular mandate. Apparently there is an option to opt out of this if you do have coverage that meets the criteria. Again, our problem is that we haven't found any carriers that do meet that. So anyway, I think most of the information on the exchange has been relayed to you. I mean, my biggest question from my clients, and I work with about 175 small employers, is what are people doing? What are other people doing? And it's really, I think, going to be a lot of wait and see. We have looked at the exchange, and there really are a lot of the same plans that are on the exchange and then off the exchange, other than I think there were 2 with Blue Cross that were different. So we don't really have a lot of other information because no other carrier has divulged their plan designs for January other than Blue Cross to us. And so we do know that the rates have to be the same on and off the exchange. So certainly the exchange is going to be the best option for those that want to convert over to that option of just giving employees a defined contribution, as we call it, where you just define a dollar amount to give to them and then they make their choice. So this has been, that's a difficult thing for employers to do because it's a big change from how it's worked. But really just to be patient, and it's really a learning curve for all of us, small employer groups, agents, everyone, and how it's going to flesh out in the next year or 2. So we keep an open mind, and we try to just learn as much as we can. So I'll probably answer any questions that you have later, but that's kind of the nuts and bolts of what you have to do as a small employer particularly, and some of the things that we're concerned about. Oh, okay, Beth Crable from Fairview Ridges Hospital.
I'm Beth Crable. I'm the president of Fairview Ridges Hospital. So I just want to give you an overview a little bit from a provider perspective. This is so complicated, and I think all the speakers have talked about, it's really hard to boil this down into a nutshell. We didn't share our presentations, and it is nice to, I think, for all of you to see that all of us have pretty consistent facts. We've taken a different slice of things, but I think we're all saying pretty much consistently. So I just wanted to talk a little bit about kind of a high-level why we need it, what are some of the new regulations that are facing providers. So as you access care, as you're talking to your employees or for yourself, kind of what we're facing, and then kind of what are some of the benefits, but also some of the challenges. Okay, so why we're talking about this. This is health insurance and health spending in the United States is really out of control, and you can see how health premiums and workers' contribution to healthcare spending is outpacing inflation and is certainly outpacing what the workers are earning. I had a couple slides that didn't show up here, but you can see that in United States, we are spending more per capita than any other developed country. So we're spending almost 20 cents on every dollar. Comparable companies are spending probably 4 to 5%, so it is a big issue. We're also seeing that as far as like the outcomes, we're not keeping pace really with the rest of the world, so our mortality rates really aren't better given the amount of money that we spend. It's important to keep in mind that when you think of if healthcare, if we rate our own personal health like 100 points, 50 of those points really are genetic, that really determine the outcome of our health. 10% is the healthcare delivery system. So I think it's also important, which is kind of absent a lot from our conversations about health reform. Some of it's the healthcare delivery system, but there are things like personal choice, diet, health, where you live, your water, clean air. That's really about 40% of what influences health. It's really the healthcare delivery system influences about 10%. So just by tinkering with the healthcare system is certainly not going to impact all the work that we need to do in the healthcare reform. I just thought this was a very interesting slide, and so because I'm sure there are many of you too who are like, wow, who's using all this healthcare? Where does the money go? About 50% of every dollar that we spend in the United States goes to 5% of our healthcare users. So if you look at this graph up here, 50% of people in the country use about 3 cents of the dollar. So we have high concentrations of a small group of people using really the majority of the healthcare dollar. Almost 98% of the people are using well over 50%. So it is really important. So if you look at the top 1% maybe uses 30% in a given year. The 5% of the population uses almost 50% of the money. There's 20% of people who don't use any, and I think that's the healthy people, the people who are kind of always think that nothing will ever happen to them. That is true for a lot of those people. You think, well, why should I get insurance because I'm pretty healthy? And then the bottom 70% uses about 10%. So it isn't equally distributed, so we should be spending most of our time in that top 5% of Americans that just need more health care. They tend to have more chronic illnesses, maybe have an episode of cancer, have a long-term illness with AIDS or MS or issues like that. You also can see how we spend. It's interesting. This is compared to European countries. So we're pretty much, we spend about the same, give or take, up to about the age 65. And then you can see a huge difference in our spend in the last years of our life, especially as people get up into past 70, which is really interesting. And I think that reflects some of the coordination of how we're coordinating our care with long-term care, chronic care. It also has to do with some of the health measures that people in other countries take with smoking, with exercise, with weight. Very interesting though. So it really is more of a senior related where we really see our disparities for other countries. And this is certainly not going to get better. I mean, everyone's heard of that term, the silver tsunami. We are seeing that just, that is also putting a lot of pressure on what's happening in our healthcare, as you can see the percent of Americans that are 65 and older. It also is when you look at the number of beneficiaries supporting the Medicare plan in 1966. So Medicare was started in 1965. If anyone remembers, in 1935, the retirement age was set at 65. The average life expectancy was 62. So really, there was no expectation that anyone would use the Medicare benefit because it was really, I think there was a quote that it was to help widows not eat dog food in the streets. You know, the few women who lived to be 65, they didn't want to have them be desolate. So we really, as a country, haven't really thought this through. So when you think of retirement age, a child born today now could really expect to live to be 100, and to be on a subsidized plan for 35 years. That's also something that we'll need to tackle. I really think today, I mean, I think you've heard everyone talk about this is so complicated. We will be talking about health care for a good 10 more years. I mean, we won't fix this in one fell swoop. The health exchange is one step. We have obviously a lot other issues facing our country on kind of affordable health care and how things are going. So you can see our kids will be supporting, you know, 2 workers to support 1 Medicare beneficiary. That really is a burden on our young people, and that's another area that needs to be fixed. And you can see just from, we talked about as an aging population, it's about a $10,000 average public school cost. The average retiree is about $25,000 a year, and as we have more and more people leaving the workforce, I mean, this is another huge issue that will need some attention. And the average Medicare beneficiary puts in probably about 1/3 of what they take out. And so I think we've seen the AARP ads of, I've earned this benefit. The average worker maybe puts in between $60,000 and $118,000 and will end up consuming close to $300,000 in benefits. So there's a real issue that we'll need to address in our country. And then certainly as people get older, we are projecting that people will have more chronic illness, and these illnesses you do need more frequent health care. So we expect the demand certainly will increase. They had talked, some of the speakers have talked, I think it's nice to see we're all pretty much the same. Minnesota certainly is about the 10% range, and we are doing well, and I think we can really thank a lot of the leaders and a lot of the legislators who came current and before, who are forward thinking, because that really helps. Unfortunately, if people don't have insurance, what they tend to do is go to the emergency room, and we certainly see that. You might not be aware, you might be that it is a federal law that anyone who comes into the emergency room will get treatment and stabilization without any regard to payment. So that is something that is provided. And so we have so Ridges Hospital, we're a 150-bed hospital. We have well over $1 million a month of patients who come in who don't have insurance, and they get free care that we subsidize. Or the other thing that we're seeing, and that'll be a concern, and it'll be interesting to see how the exchanges roll out. We have more and more patients who come in who have a $10,000 deductible. I bet if I did a show of hands in the room, I mean, it's well over half the patients that we're seeing. Not many people have $10,000 in savings to cover. So even though we talk about people having insurance, if you have a high deductible, we'll continue to see those patients in the ERs. We have patients who come in who, even to pay a $50, there's a lot of opportunities for access. We're so fortunate in Minnesota. We have fabulous clinics. I think all of our clinics have extended hours. We have urgent cares. We have the Target clinics, the kind of every CVS clinics. But they all, if we have patients who, if it's a $50 copay to go to Target and they don't have the money or whatever, they'll come back into the ED. So there still could be some continued issues with people maybe not choosing well and continuing to use the ED as their kind of primary source of care, which is very expensive, because once you get into the emergency room, there's a whole list of regulations that are different than if you went to like a Target or a different, because of regulations that we have. I heard an example the other week about when you compare the IRS rules to Medicare rules. So if you took like a room here, the IRS rules, which have been in place for about 101 years, I think 1912 it was enacted, would fill about 1/3 of the room. The Medicare rules would fill the whole room. And with the new health reform, we're expecting 20,000 more regulations in healthcare. So again, it's complicated. There's a lot of things you talk about. The cost of, an example of, and we hear that a lot. Why can't you just say what your price is? We have hundreds of thousands of prices, hundreds of thousands, Medicare pays one thing, medical assistant pays another, insurances all were negotiated differently. No one ever pays a price in a healthcare. Nobody ever pays your listed price, but you have to have a certain listed price so you can negotiate differently. Our discount rate of a hospital on average is about 60% of what's listed. It is, and it's so complicated. That'd be a whole nother talk, but how to price certain things are easy to price. A lot of it depends on if you have diabetes, and if you're 95, your care, you might need a little more help than if you're 65, and so it is so complicated. And what I find, and I think you've all seen this too in your businesses, the more complicated things are, the harder it is to have transparency. And then when it's hard to be transparent, I think then it's confusing and there's a lot of mistrust. We're really fortunate, if you can see the dot here, Minnesota is right here. So we have very low cost and very high quality. Actually, we're one of the low cost providers in the country. So I think as a provider group, we're doing really well. There we go. So we're really fortunate. North Dakota's up there, but it'll be interesting to see. You hear a lot of things stressing their health system. Talk about a lot of pressure with all the new industry, and they're really having a hard time keeping up in that state. So what we'll see with as a provider, continued downward pressure, a link that was mentioned to some things to quality. About 80% of it is really helpful. The last 20% we're chasing is probably more paper compliance, to be honest with you. So you have to try, if an antibiotic is given in certain situations 1 minute late, 1 minute, that's a 0, and you get a 0 score. I mean, so like all of those things, you need to really, I think it's well intended, but we are probably investing more resources to complying with some of the value-based purchasing than actually, than it's worth for our patients. So again, with the regulations, we got to always be watching that. And then some of the, what was mentioned, kind of the bundled services that's happening. So we will see in healthcare probably over 200 billion cuts, and a lot of it is in penalties for value-based purchasing, readmissions, some of the performance measures. We are certainly, well, if you can see where the typical health, it's hard to maybe read in the back, how the healthcare dollar is spent. Currently, about 40 cents of every dollar is spent on hospitalizations. And what we are hoping to go for, I think, as a nation is decrease the whole spend and reduce that to 25%. So we can do a lot of that with readmissions, which I'll talk about a little bit, and are also things that used to be, I've been a nurse for 30 years. When I started in nursing, if you had cataract surgery, you would be in the hospital overnight with sandbags by your head. A colonoscopy, you would be in the hospital overnight getting a prep. So we have done, I think, amazing work in trying to move things safely to a lower cost setting. So things that used to, and I think you see that now, and I'm guessing that there are many of you, a lot of it's regulatory, and a lot of it's we're really trying to, how can we do things safely? We still have a whole consumer base that maybe hasn't caught up with that. So you have someone who's, boy, I'm really sick, I'm gonna come to the ED, and I'm sure I'll be admitted. It's really difficult to get in the hospital. It really is. I mean, there's really high criteria from Medicare, so we don't just admit somebody because they need a holding tank. We admit them if they really meet clinical criteria, and that is really hard, I think, for patients. And maybe some of you had that experience who had a parent who think, you're kidding, they're 95 and they're in a lot of pain. They might be put in a 12-hour observation unit to watch and assess, but we're really careful with patients that are admitted to the hospital to use, because that is the highest cost place. We want to be good stewards of those resources and care for patients safely. So I talked a little bit about the value-based purchasing. So there's some reimbursement is tied to how we're doing with these quality measures. The readmission policy, so we're doing a lot of work with readmissions for Medicare patients, and that's a penalty if patients come back for any cause within 30 days. So there are some things that are great for patients, so we're working hard to make sure they have a good handoff, that they have a follow-up in their clinic. What it doesn't account for is we have a fair amount of patients who will just be, they're not really compliant, so they'll just tell us we're not going to take the medications and stand out, smoking, and we know they'll be back, and that's a penalty to the hospital. Or we have patients who say, well, I really do want to try it at home, even though the caregiving staff is saying, we really are worried about you. You'd be safer if you went to a long-term care placement for a while. If the patient refuses and then they come back, that's a readmission penalty for the hospital. So it is interesting where sometimes we assign responsibility. It's on the health system, but we really haven't moved, I think, to that next level, which hopefully we'll get to as a society of some personal responsibility as well. So what we're working on doing is managing chronic illnesses better, and there's a lot that we can do. Reducing unnecessary hospital admissions, reducing emergency visits, the high-end diagnostics and tests. And so we really are, believe it or not, working really hard to what's the best care for the patient, but what are things that they really don't need. It is difficult. You have a lot of patients who come in with an idea, like I want a CT scan. I fell down and I've injured my knee, insisting on certain tests or insisting on antibiotics. I've had a sinus infection for 3 days, and boy, I want to get antibiotics. We're working really hard. You have providers saying, really don't want to do unnecessary tests, prescribe unnecessary medications, but there is some tension between consumers and providers at times as well, because you have patient expectations of I want all these things done, and you have providers saying, well, that really isn't best practice. And so we're not always together between the provider and the patient. And then the end of life spending, there's so much more we could do for that. And it's unfortunate, and I think it's what's nice about a conversation like this is such a complicated issue, healthcare, and that it can't be decided in sound bites and 10-second messages. It really is going to require a robust dialogue as a society. And I think for all of us as citizens of Minnesota, we need to set the table well for our legislators to have a thoughtful conversation. You saw what happened, that was a couple years ago, and we're talking about this, that end-of-life planning turned into death panels, and really, that wasn't going to happen. So I think we need to take responsibility to understand that this is really complicated, and we need to give our legislators set the table well so we can have complicated conversations without getting so polarized at the end, because it is really complicated. We talked a little bit about that. This really, this was mentioned before, healthcare was really started as a fee-for-service. So you provided a service and you got money. And so that's really been the economic chassis of healthcare since the 1950s. And there is then the more you do, the more money you get. So it really was, you're really incented to have a lot of volume. What we're moving toward is global payment, value-driven care, looking at outcomes, and we're kind of stuck, I think, in this a little bit of this messy kind of how do you move from you have a foot in one camp. You still want enough volume so you can pay your bills and you can cover your fixed cost, but you want to move to an area where you're really have shared savings and you have high quality. So we're in and the payment systems haven't caught up with healthcare. We have a few with most of our large insurers. We do have, like Blue Cross as an example, where we have some shared savings, because in the old model, for instance, if we had a clinic where you could call your doctor and you wouldn't have to come in, you could do it all by email, that'd be great for patients, but then how do you pay for that time? Because the physician is still spending time in the staff, so there was kind of a disconnect between the payment and the care. So we're making some progress with our payers where they have some allowance, so we can do some cost-effective things and innovate care. I think Fairview has a really great, it's called Zipnosis. You can go online. I mean, we're really working hard to how can we start to change how we're providing care. And as we mentioned, I mean, it really is the new elements, a lot more with the second bullet, care coordination for complex patients. That's really where we can spend the most of our time. Better handoffs, better coordination. I think we'll see, healthcare has been fairly siloed. I'm guessing many of you in the past have had an experience where you went to the clinic and then you had certain tests or labs done. You went to the ED, they had no understanding of what you did. You had to repeat a lot of those tests. You maybe went to the nursing home or somewhere else. So we're doing a much better job with electronic platforms so we can share information, so we don't have to repeat tests, so we can coordinate care better. And I think that will be certainly better for our patients. So what we know for sure, we spend a lot of money on healthcare, and we're on track to keep spending a lot more. There is a wide variability in spending across the country. Again, we're really lucky in Minnesota. Most of our dollars are spent on a small percentage of the overall population. We don't have great great outcomes, especially for that population. We've certainly known that for a long time. We can do better, and we are certainly committed to doing better. So we are investing in looking at, you've probably heard the triple aim, how can we improve healthcare status, lower cost, and improve patient experience? We have so all of our clinics at Fairview, and I think really most of them in Minnesota, are healthcare certified homes. So you provide your clinic services, but they're also enhanced services with social work, with care management, so we can really help those high-risk patients kind of navigate the system, because it is really difficult for some patients if they're using care a lot to know where to go. And if your only response is, I have to call 911 and take an ambulance to the hospital, we can do so much better than that. So we are really working hard to manage those patients. We have, and as was mentioned with pharmacy, the average medications of patients in the hospital, they're on an average of 23 medications. I mean, can you imagine managing those meds and then coming in the hospital and then having all those change and then going back home and trying to figure out how to manage that? So we're doing a lot of work with that. So we are trying to manage kind of that top 5%. We have contracts with them. We're looking at the highest risk, the most complex. So they have care coordinators who are checking in on them. If someone is admitted to the hospital or the ED, they're followed up the next day with, what happened? Can we coordinate your care? Can we get you into the clinic? Really working hard for those patients. So with that, I'll turn it back over to you, Phil.
Thank you, Beth, and thank you, panelists, for a very thoughtful and thorough discussion of healthcare. We'll now open it up for questions and answers. Hopefully you've learned a little bit and maybe come away with a few more acronyms that you didn't know before. So if anybody has any questions, we will field those now. And if you want to direct them to certain panelists or in general, please feel free. Yes.
Yes. So the question was the stat that on average a member has 13 prescriptions per year. I'm assuming that those are refills on maintenance meds typically. I mean, obviously it varies on a person-by-person basis. But, most of the drug spend is maintenance meds. And so that's what that stat is.
Lynn, do you want to tackle that one and repeat the question too for the...
Go ahead and
Okay.
repeat the question.
Everything that we have heard is that you cannot pre-tax premiums on the exchange. I'm waiting for something in writing that says you can pre-tax.
But you said they're going to be taxed.
I'm sorry. Oh, that you can't take it on a pre-tax basis.
That is my understanding as well.
But on this thing, not only are they not pre-taxed, but we're going to be taxed.
Well, the taxes, there are more taxes that are going to be built into premiums in the small group market. Yes.
Twice.
Kind of.
And Lynn, do you want to talk a little more about the healthcare taxes on insurers maybe?
Yeah, there's a variety of healthcare taxes that are in small group and individuals. And like I said, it's not just the new taxes from the federal insurance tax and the premium tax that comes from the Minnesota Exchange. It's the Minnesota Comprehensive Health Association assessment for premium deficiency, the reinsurance tax, and I have a whole, are you pulling up that chart, Phil?
Yes.
Trying to. There's a insurance premium tax, a Minnesota Care premium tax, provider tax, which is 2%, but the 2% actually goes across the self-insureds as well as the fully insured market. So that's the one that hits the entire market, as opposed to some of the new ones that are coming on that don't hit that self-insured market. So there's old taxes that were there in the past that were built into the premium, as well as the new taxes that will come up.
And I'll ask you a question. Where is the revenue going?
The revenue is going to a variety of places, and the legislators in the room can probably help me as well. But some of it goes to support the Minnesota Care population and provide care for them. Some of it goes to support the operations for the Minnesota Exchange. That's the up to 1.5% for next year and up to 3.5% the year after. And some of it goes to pay for those subsidies and for the operations of the implementation of ACA. And the MCHA assessment goes to pay for the premium deficiencies, because MCHA, those in the high risk pool pay a lower premium than what it actually costs. There's always deficiencies, so the health carriers put into the pot, it's 2 to 3% assessment for the. MSHA is going away in 1/1 of 2015, where there won't be any new enrollees. However, the assessment will still be in place because, one, there's still people in the program this year, and there will still be people in the program next year. So eventually it'll go away, but it'll take a couple years to phase out because we'll still be paying those deficiencies.
And who's processing the MNsure?
Well, there's 5 different carriers that are on for the individual market and 3 for small group. So depending on the carrier that the individual or small group chooses, that carrier will be processing the claims.
Are those private?
The
The
private,
people processing them?
the private insurer carriers, whoever
Then
they,
why are we taxed to pay them?
there's a part of it that's an operational component of MNsure, to put together the system, the web-based system.
Very much like when the MSHA tax when MSHA assessment went into place to pay for putting MSHA into place because of what the benefit was going to be to the private market. So you did the math after we reduced uncompensated care, and actually in the private market you saw better benefits than what we were paying for. So we had less uncompensated care, lower rates of growth in our premiums. So it's one of those pieces of complex investments. But we'll have to continue to look at the way that we tax, and because of ERISA, it's the small group market that gets hit disproportionately with taxes, and I think that's a problem. The provider tax is scheduled to go away in 2019. So that's another piece. And interestingly enough, as Lynn said, that's the only tax in the healthcare marketplace where Minnesota can also see revenue from the large self-insured plans.
By 2019, I'll be out of business.
And I mean, the other piece of that benefit is tax incentives for providing care for small employers. So the small employers are also eligible, as Tom said, for benefits as well to close that gap in the cost.
The question was, does that depend on the health of the individual?
It's based on how many employees you have. You have to have under 25 employees and an average salary of $50,000. And the highest, I believe, credits go to those with like under 10 employees. So primarily I've seen some nonprofits apply for it. Well, I definitely would think that might be a benefit to you if your employees are fairly low income. If you pay them smaller salaries, so it's something to look at for sure with your accountant.
There is no evaluation for pre-existing conditions or anything like that.
Right.
So it doesn't matter what the health of your population
Doesn't have anything
is.
to do with that.
You know.
The question is, how
I
do
have no idea.
the tax credits come back to a
I
nonprofit?
don't know.
Yeah, and I don't know the answer to that
Yeah.
either. It is a healthcare tax credit. It's not a premium tax credit as it's referred to for the individual. So
No.
I'm not sure.
Well,
It's one to look into.
and I was going to say, as a nonprofit, the way that the healthcare taxes get put into place, are you as a nonprofit exempt from all of the healthcare taxes? Because they're actually built in many ways to the healthcare system. The provider tax, as an example, isn't a separate line item on your bill. It's built into what your health insurer gets charged. So you are also eligible then for the tax benefit as a nonprofit in order to, again, close the gap so that you can provide health insurance to your employees, so that there's an incentive to provide health insurance to your employees.
That's the problem with averaging. You know, what's happening. You had this, and now we're coming to this, and this is the average, and so.
So there's no benefit for staying healthy.
They have eliminated in the regulations some premium rating. We can rate for smokers versus non-smokers, and some age rating, which was already in effect in Minnesota. But there are some things that have changed significantly on how the rating, and that's to average it out. And some of those young, healthy will see a higher rate increase than the older population because it's averaged out again. Older, maybe not as healthy, will see maybe a little bit lower rate, and the younger, healthier may see a higher rate. But it's all based on individuals, as I said. It's to your circumstance and what group you have, or if you're an individual purchaser, and how that works.
Next question. We could get into rhetoric all day. Not rhetoric, but I mean, it is amazing, the stories.
I had a question. It said,
So tax credits to full-time versus part-time.
So the tax credit is to you, the employer. And to qualify for that tax credit, you have to meet in certain criteria around how many full-time employees you cover. And so full-time employees defined as 30 hours or more on average per week. It doesn't matter how many part-time employees you have and whether or not you provide coverage to them. It's just really, the criteria around employees and coverage is for full-time employees.
Yes, sir.
Oh, that is just a great question. If anyone, just the complexities of, and that's where we're trying to do a better job, and so we are working like with our long-term care partners, and they're doing, I think, a better job of not, because really to call an ambulance, because you're right, once you come into the ED, if you don't have a health directive, we legally have to do everything we can, and so, excuse me, a lot of people haven't thought that through. There's also such a, it's not just nursing homes now, that's really a small part of kind of the senior market. It's all this, which is wonderful, all the assisted livings and all the senior housing. There's a lot of seniors who maybe don't have a coordinator, and that is a big problem, because they call, once you trigger that, you call the ambulance, they're obligated. They can't say, because we have such a litigious society, and so we do, unfortunately, it's that one case you don't want to get in trouble for. It starts the process, they come to the ED, we need to do what we can unless they have a really good directive. And that it's not good for the patient, they don't want to be there. Oh, we could do a much better job. And that's where it's complicated. We're trying to connect, and I think that's where we can do better coordination with the senior centers and the hospital. But there's a huge opportunity. That's great. Yeah, that's a great point of kind of end of life care. There's a lot of, we're trying to go out in the community about, health directives, and then there's a lot more from, you hear people say, well, if something happens to me, just pull the plug. Oh my gosh, there is like years of care and thousands of dollars between that. There's so much gray area, and if the families don't have consensus. So this is broader than the healthcare delivery, because then we do get kind of caught in the middle of, we have to do what's legally right for the patient. And if you have conflict, if you have one family member who's in disagreement, but that's where as a society we could do a better job, certainly. And that's where I think some of the other countries have a better handle on kind of end-of-life care. In some areas, like in the developed countries in Europe, they tend to, they live, and then when they get a sickness, they die faster, so they kind of live until they die. Where in America, we have a lot more, maybe 18 months of in and out of the hospital. It's not always the best care for patients. That's not where they want to be. Everyone gets kind of caught in the system, so there's a lot of opportunity. So, yeah.
I put a slide up there for you.
Oh, yes, there we go. And there's a slide.
Now that I've mastered the slides.
I always think too, though, there's not enough communication with children and their parents as parents get older of what are your wishes. Nobody wants to talk about it because you don't want to talk to them about dying. But to have the conversation so that when the time comes, all the siblings know what their wishes are, and it's easier to follow through. We certainly did that with my mother, and when she got pneumonia, I took her to Fairview, and I was a little nervous because I thought that they would force me to treat her. And I said, I know her wishes were to not be treated because, and they said, that's just fine. you take her back and, care for her and whatever. It was really a blessing. So I was really pleased with how they responded.
Question is whether or not states are given the tools from the federal government to disclose what is working, what is not working, back to the federal government, correct?
I think that's a really great question. I think that this is a place where we see the work that and I'm sorry I can't see you behind the pillar, but we see the work that has been going on in Minnesota over the years. The one thing about the healthcare system is there certainly isn't a shortage of data points to analyze. And so determining what works and studying what works is going to, from a policy perspective, going to be critical as we continue to roll out healthcare reform, because this is not a one and done discussion. We are going to, as Lynn said, face challenges, find successes, and we are going to have to, as policymakers, make sure that we are continuing to move in the direction of controlling costs and ensuring access, and making sure that our system can be most efficient, and it's going to be those data points that are going to help us. But historically in Minnesota, we've been doing that. I mean, plans provide a lot of contact information and what do you call it again? When you
Encounter data?
Your encounter data about where our healthcare dollars are being spent and how our healthcare dollars are being spent. And part of that public-private partnership we see is that the plans are very engaged with the government on making sure that we have that information. So.
I just want to add, and I think you're right on, Lori, but I want to add, I think one of the data points that will be looked at across the states is the amount of uninsured and the rate of uninsured. Mm-hmm. In Minnesota, we're lucky we have a relatively low rate. We want to keep it low and make it go even lower, but I think that'll be a good indication. We'll get that fairly shortly after the end of next year of where our uninsured rate is.
Yeah, no, that's a great question. Actually, and at Ridges, we're bigger than Southdale. So our ED will see over 53,000 patients. And so, which is a great, we're so lucky to live in a country where just immediately you can be taken somewhere life-saving. I mean, that's phenomenal. The other part of that, though, is we probably easily 1 out of 10 people who come in don't have any access, or choosing to not, choose something lower. It is kind of the front doors for everything. It's a safety net, really. I mean, hospitals are really the safety net for social problems, homeless issues. I mean, because that's the place that's open 24/7. It's safe and it's free. I mean, you get a bill, but you don't have to pay it. I mean, so it is kind of those open doors. And so there's been a lot of question about with health reform now, and if more people have insurance, will we have enough access to primary care? So will people move there? That's a question. Or will now people be using ED more because now they have insurance? Because there is a group that maybe won't go to ED because they're worried about having to pay. And so it's really been hard to plan kind of the access points. But I think, unfortunately, by default, EDs have been the place at least you can go and get some attention, and that isn't always the best, certainly best place for patients. So
I have a
it's hard to
question,
plan.
Beth.
But I don't know if I answered your question. But
What I've always wondered, there's so many people that go into the emergency room that really they should be in urgent care. Would it not be possible to have that type of a situation set up next to an emergency room where you would just triage your people and, okay, get that one over here because he really just needs an antibiotic? I mean, wouldn't that save money?
Yeah, and actually we are starting that. What what we hope to have is obviously a clinic so you can see, because there are, it is to have, if any recommendation from today, get a relationship with a primary health provider, because it is amazing how you're going in for a sinus infection, but boy, they know you, or they can tell something else. So that's helpful to get that care. We are doing more and more of what's the least cost. The hard part is, there is a cost of a 24/7 trauma, level 3 trauma that's open, and a lot of the urgent cares and things, tend to close at 8, and so that often it's usually the nighttime where you have that, kind of one crew available. So we are looking at ways to to do that or
Yeah.
to send people over. That also, it depends on the area. It's expensive to have two separate staff, you have to have two separate systems, two areas. You can't mingle because there's so much regulation with ED. I mean, you really cannot make a mistake with not treating a patient. It's so high liability, so.
I think we can all assume that the emergency room care
We're trying our best, we are.
Yeah, that emergency room care is probably the most expensive.
Yeah.
So how does a benefit manager, whether a pharmacy or a health plan, really look at the right care at the right time, and how do you address that? And what have either, I'll say, Prime Therapeutics or Blue Cross done to address that issue?
Well, we have a bunch of different care coordination and utilization management programs where we look at, I think most people are not looking to abuse the system. I think in a lot of cases it's just education and knowing what other options are available. So we see that in the pharmacy world around brand and generic drugs. Generic drugs are typically the exact same, formula, exact same ingredients, but people just don't understand that. And educating people on that fact is sometimes difficult. And so we have a number of different, I'll call them outreach programs where we identify people who may have lower cost options available, either, the care delivery setting or, in our case, the drug that they're taking. And we reach out to them and try to educate them on what their options are.
Thanks, Val. Yeah, Blue Cross does do a lot with care coordination, especially with our Medicaid clientele, and offering them a nurse line where they can call in and get a care coordination or a consultation, and where's the right place to go at the right time if it's a certain thing that can wait until tomorrow or things like that. So we do a lot around that. Obviously, Blue Cross is very supportive about wellness initiatives and keeping people well, working on obesity and tobacco use prevention, reducing tobacco use. That's always been a very high profile. We're very concerned about that, and we have taken a lot of initiatives, including raising the tobacco tax this last year, to help those smokers quit or to get the kids not to start at all. So those are some things that we've really done, and we really try to emphasize is keeping people healthy in the first place so they don't have to go get care, and then trying to help them to get care at the right place at the right time so they're not overutilizers. But we also want to make sure that there's not underutilizers as well. Working for a health plan, I know when I broke my leg, I waited till the next day to go in for a regular appointment. It turns out that you can actually go to the emergency room for that. But so there's the right time and the right place. There's the underutilizers and the overutilizers. We have to get a good balance.
And I would just add, I think we need to acknowledge that it's a journey that we'll never be able to declare victory on. I think part of the problem, right, is if I have chest pain, is it because I ate that big burrito for lunch, or is it because I'm having a heart attack, right? So we try to move to this sort of consumer-based model with healthcare, which is, an aspirational goal that we should all work towards. But I think the reality is it's not like buying a toaster at Target. I mean, we know, do we need that toaster? Do we need the features or not? If we decide we want this toaster and it's really the wrong toaster for us, it's not going to be a life or death situation. And in some situations in healthcare, it is. And so I think I think we all get really frustrated that we can't figure this out. And I think part of it is we may never totally figure it out. We'll get really close, and maybe that's good enough. And I think that that's got to be an element of it as well, is just sort of figuring out what is it exactly we're trying to get to.
And I think, go ahead.
I think Lori wants to add something too.
I was just going to say, in addition to some of the innovations that have been going on in the private marketplace, to everything from the nurse lines that both health plans and hospitals are running, so that you can help triage yourself at home. I know anybody who's got kids loves the nurse line, right? And that's gone a long way. And you look at encounter data that the health plans have about ER utilization, and one of the big changes that took place was cost sharing, and that you all of a sudden started seeing a bill for going to the. Do you remember the good old days when you never saw a bill when you went to the doctor? All of a sudden we knew what it was costing us. It was costing us some money out of pocket, and so that actually did change consumer behavior, and there are data points that back that up. Additionally, from a policy perspective, there's been a lot more in terms of the healthcare reform, the way that we pay for care, that encourages best practices. And patient education is a big piece of that. When is the right time to go to the ER? How do you manage your disease appropriately so that your diabetes doesn't turn into a need to lose a limb. And so those pieces have been actually reforms that we've seen in the private and in the public sector as well. There's the way that we pay for care. So consumers have put a lot of skin in this game, and I think that, and as employers, you guys have been there right along with them. So I think that's important to note.
And Lori, you also mentioned in your slides the fact that the state of Minnesota and other employers have contributed to trying to keep people from going to the ER or even going to the physician if they don't have to by becoming healthier. And maybe talk a little bit about what the state has done on SHIP grants or funding over the past couple of years.
Yeah, that's something that's exciting for me because my background is I have a lot of background in health promotions, policies that promote health and how can we be healthier. Lynn mentioned tobacco policies that Blue Cross has been very active in leading. The state of Minnesota put together a program a few years ago called SHIP, Statewide Health Improvement Program, but you can't say that, you have to say the acronym. And it provided grants to local communities to promote health and wellness. Dakota County has taken this and run with it. SHIP was part of the 2008 healthcare reforms that were passed and had broad bipartisan support. Those monies were cut over the years in the budget. We restored a good deal of SHIP funding because the outcomes are there. I mean, we see lower healthcare costs with reduced smoking prevalence. We see fewer admissions for serious health complications from somebody who has a disease management issue when they're able to access programs that can support them in their disease management. So, and the best places to provide those things are not from the state or the federal government level, but on the community level, because our communities are unique and we can identify, the communities are the best folks to identify the right interventions at the community level. So that funding was restored. It's not a ton of money, it's $40 million, but it's been money that's been well spent and gone a long way. And private entities such as our hospitals and health plans have also stepped up and provided granting as well. So there, again, is another example of the way that the private and the public sector are working together to help control healthcare costs and create a healthier population.
Carriers.
Oh yes, the carriers. So we are owned by a number of Blue Cross Blue Shield plans. And so we are the drug benefit inside a number of Blue Cross Blue Shield plans across the country. We do have a very small proportion of our business, which is we provide administrative services to private employers directly. So some very large employers sometimes contract with a PBM or pharmacy benefit manager separately from their health plan. And so that's a nuance that none of you need to really know about, but we do have a small percentage of our business that does that. So the question was, how many different plan products do we work with? So it's, kind of is a definition of what your product is. And so I'll define it as a bundling of different plan design features. So if you want to think about a pharmacy benefit that is, let's say, ease of use focused, it would have a very broad network. Just about any pharmacy would be in the network. It would have a very rich formulary. A formulary is sort of a jargon for a drug list. So it would include brands and generics as covered. And so that might be something that's more expensive, but it's all inclusive. And it may have different care coordination and utilization management programs associated with it. Another one might be, let's say, a low-cost product. It might have a more exclusive network. So in Minnesota, for example, there's a Target all over the place. So you might have a network where you get a greater discount if you go to a Target versus any other pharmacy. You might have a drug list that's focused on generics as the primary coverage. If you want to have a brand that has coverage, it might have a much higher cost associated with it via the cost sharing or the copay. So I'll sort of define the products as a various bundling of features. And there's a number of different varieties of those bundles, I would say, and it's kind of something we figure out in collaboration with our health plan partners around what it is they want to offer to the marketplace. And typically we try to sort of mirror the benefit to the medical benefit, just again to try to make it simple for the member to understand what it is they're using. So if the medical benefit primarily has co-pays on it, the drug benefit will primarily have co-pays. If the medical benefit primarily has co-insurance, which is a percentage of the cost, then the drug benefit would have the same thing. Does that make sense? Good.
Yes. So the question is the federal tax rate versus our percentage of uninsured.
That is a great point. And it's something that we as Minnesotans and leaders in healthcare in Minnesota have been talking about for years. The fact is Minnesota has better outcomes and lower costs than states like Florida and Texas, and yet we don't manage to reap the same federal benefits. And there's been attempts to level the playing field over the years. They have not been widely embraced across the country. And you're right, there's a terrible inequity, and we need to work as policymakers, and I think our private market needs to work to make sure that we've got our folks in Congress making sure that they're saying Minnesota has essentially, we've paid up front in terms of innovation, in terms of keeping our uninsured rates low, in terms of pushing quality in our system. And we're going to keep working there. I mean, to Tom's point, this is an aspiration in our state. But it doesn't mean, it means that Minnesota should reap the benefits. It doesn't mean that Minnesota should have to be penalized because other states aren't as effective and aren't as efficient as us. With the Affordable Health Care Act, you are seeing policies that have worked to lower costs and improve quality in Minnesota go nationwide because it's a federal law. So there is a piece of the Affordable Health Care Act that is aimed at leveling the playing field so that high quality, low cost states like Minnesota can reap more benefits, and low quality states like Florida, not to pick on Florida, it's really pretty down there, but they haven't had the same outcomes in healthcare as Minnesota, and that they have to put more skin in the game. So.
If I could just add to that, that's a great point. The other part, I had like 300 slides and was told, okay, you have 15 minutes back. So the slide I took out is that the revenue per beneficiary to get care in Minnesota compared to other states, that's the other part of why we're low cost, as well as what was commented on, is that we also are paid less. So if you were a same patient admitted for like pneumonia in Minnesota, you will get 3 or 4 times more money if you have that same diagnosis if you're admitted in Florida or Texas or New York. So Minnesota, because when the Medicare reimbursement was fixed, it was in 1982 when the DRG, so hospitals used to be paid on cost. That was up till 1980, you were paid on cost, and Minnesota tended to be lower cost. Well, then when they went to a DRG payment, the higher cost states, that's where their payments were fixed. So we're well behind the nation. So like in Florida, Medicare is one of their best payers. In Minnesota, all the hospitals in Minnesota are working on an initiative called Try to Break Even on Medicare. And so, I mean, if you think about it, if you run a business, if you just break even, you're not gonna stay in business a long time. So that is not a good payer really in Minnesota, where in other states they get a lot more money. So there's a lot of inequities, not only with uninsured, but also in the payer rates, and who's going to vote for that? I mean, let's be honest. Who from New York is going to say, yeah, you're right, we've been getting paid too much, we're going to go to Minnesota rates? I mean, I don't think that'll ever happen.
So Beth,
Yeah.
What is DRG?
Oh, the diagnostic group. So when you come in, and there's hundreds of thousands of those, that's the other part where it gets hard to price. For pneumonia, there's maybe 50 categories. It's pneumonia with this, pneumonia with this. I mean, it's very complicated. So you're paid, when you come in the hospital, you're basically paid, this is the lump of money you get based on your diagnosis, whether you stay 3 days or whether you stay 2 weeks. I mean, you're paid a set fee. So, anyway, it's, yeah. And then I have 2 more hours of talk on this. No.
I
I just want to add a couple things, and they both make great points, and we've been working with our congressional delegation because for Medicare, we are a low-cost, high-quality state, but our congressional delegation is only 10 compared to Florida and Texas, which they have the votes, and we don't have the votes. And so it's very difficult and becomes very political. We just don't have the delegation, the number of people to make that change. So it is something that needs to be changed. We've been working on that for many years. The other thing I want to add is with the with MNsure and the individuals and those able to receive subsidies to pay their premiums, we've very much been encouraging people, if they're eligible, make sure you go and get those, because that's federal tax dollars that we're paying in that we should be getting back. And so when they come to our website to look at insurance, we have a calculator to see if you're eligible for a subsidy, and we're saying, if you are, go through MNsure, because you can only get it if you go through the exchange, and we want you to do that.
And Phil, one more, just let's not forget that one of the most significant aspects of the Affordable Care Act, if not the most significant, is the individual mandate. So it will be illegal to be uninsured starting in 2014. And while the penalty for that is not very significant the first year, it does become pretty significant starting in 2015. So that won't solve the entire problem, but it will help.
Vicki?
Workforce is competitive in Minnesota.
Yeah, thanks. Everyone heard the question. Just Ruth, workforce. Well, there's a couple issues that probably facing every employer, but certainly facing healthcare. The mean age of our physicians is 53. So, I mean, very older workforce. The mean age of nurses in the hospital are 49. And so when you think about it in healthcare, I mean, it's most of your hours are evening, weekend, nights, holidays. I mean, it's not a Monday through Friday job. We do again when we have sometimes a shortage, or like when we're going live with a new electronic medical record, we get outside agency pools. Workers are paid more in other states. So there is, I think that's the other worry that we have with everyone else of training healthcare providers. We're anticipating a physician shortage. Now we're doing some innovative things, which I think most are, with really having people work to the top of their license, using a lot of extenders. PAs and nurse practitioners are fabulous partners in the physician team, more team-based care. But that's certainly something, and that is kind of the big question of, will people use care better and use, so the resources in the hospital will be adequate, or if we continue on this path of not really owning your health and taking care of yourself and exercising and quitting smoking, it could just kind of overwhelm the resources we have, and there isn't a huge pipeline of healthcare professionals, so that's another concern.
And there was a lot of talk during the federal reform debate about if we have more people in the pool, costs will go down. And curious if any of our panelists have an opinion or thoughts on that issue. Lynn.
Just curious, Lynn. Absolutely. I mean, I think the more of the healthy young individuals that we bring into the pool, the better. And so we're concerned about that, because they may also see the most impact on their rates, bringing them in. But those are the people that we really want in the pool, and I think Ida can agree with me on that. And it's hard to get to them because of the cost. I mean, they're at the early stages in their work career, and they're not making quite as much money. And so if they're looking at health insurance premiums compared to going out for Thursday or whatever it may be, it's a toss-up. And so it's hard to make that decision. The individual mandate will help. The penalty is not huge the first year, but again, it's $95, and the fact that there is a penalty and they should have it, that will go up over years, and we hope that will entice the young healthies to get in the pool to help mitigate those premium impacts.
Joan, do you want to add anything?
Well, I mean, I'm always a person that looks at the downside. What's the worst thing can happen? And it's just the way I am. But my concern is rolling that MSHA pool in. We know that they're high users anyway, so that concerns me. And then how was the pricing, how possibly could they have known what price points to put on the exchange? Because there's been no pool to base it on, and what's going to happen year 2, 3, 4. And I hate to see a group break up and throw everybody into the exchange, then 3 years later say, well, that didn't work, let's come on back. So, I mean, I do have concerns with that. I mean, it's the realism. I'm working in this business too long to not understand cause and effect of, bringing a pool of MSHA people into the exchange. So I'm hoping all those young, healthy people, and a lot of my manufacturing groups that, have people that aren't insured, or maybe they're in my grocery stores. I mean, really, we're encouraging them to talk to the employees, at least let them know about it, because those are the people we want on the exchange.
Go ahead, Lori.
Another piece, and I think it's smart to be cautiously optimistic. That's the balance that I'm hearing here, because Minnesota was so far ahead of the game in terms of working to drive down or control premium prices in the private marketplace through some of these public policies and public programs. We're not going to probably see results like they've seen in places like New York City, where all of a sudden they had people who had been uninsured all their lives and not had their disease managed, who now are part of a disease management program, who are utilizing healthcare in a much more efficient way. But that said, we are going to see those kinds of benefits in Minnesota, most likely that disease management is going to be a big part of what's going to happen when we get more people insured. So you've got the balance of the young, healthy people who help, balance out the premiums that we're all going to pay. But in addition, you're going to have people who are chronically ill who might be receiving care in a really inefficient way, that are now going to have their diseases managed. So are you going to be treating a diabetic for blindness, or treating a diabetic with amputation, versus having somebody who gets to see a care provider on a regular basis, make sure their blood sugar is under control, and be like my grandmother and live to 96 with diabetes and no diabetic complications. So that's going to be and that's why, we almost go to, when we talk about healthcare policy, that coverage is really important, and that universal coverage is really important. And that's why, because that's, to me, one of the keys in ensuring that we can control costs in the long term, because people are living longer. People with chronic illnesses are living longer. You look at a child who's born with Down syndrome, their life expectancy is almost normal. That was unheard of 20, 30, 40 years ago, that they would live to adulthood. And now we're looking at long-term care for people with diseases who never would have lived into adulthood, and we're looking at geriatric care for these populations. So the landscape has changed, and disease management is going to be a big piece of that.
So the question to the panel is, which one of you five is going to take care of the silver tsunami?
Well, I think the comments that Lori made, it is, with having the uninsured move in, that's one piece of what we're trying to do. We also are trying, when you look at chronic illness, most of the people with chronic illness probably have some type of insurance. Either they're seniors, or else they have a disability and they can't work, and they're in one of the wonderful Minnesota programs. We certainly, as a provider network, can do a better job of coordinating. I think the questions of 10 years ago, it was just kind of usual. You call an ambulance, come into the ER. We're really working hard to prevent that and coordinate care better. And there's so much technology that's available now for seniors. It's amazing that some of the new senior apartments have sensors that can tell if someone is going to the bathroom more than usual, and that could be a cue for a urinary tract infection, or if they're not eating, they're not going into their kitchen. There's a lot that we can do. So I think part of that, is we can do a better job of coordinating that long-term care, and that it can happen in people's homes. So it doesn't have to be, I think we all think back in the, in the 70s, you go to at 67, maybe you just pack your suitcase, go into a nursing home. Very few people are living long-term like in a nursing home. So I think we're doing a better job. So there is, I know we've talked a lot about the exchange, but there's a whole delivery component that we are doing better at coordinating care that will affect just exactly your point.
And I think that we have a great idea for another discussion.
Yes.
Right.
It's long-term care insurance, because everything we've talked about today doesn't have anything to do with long-term care. Medicare doesn't pay for long-term care, and we have not kind of solved the quandary of the fact that most of us don't carry long-term care insurance, and almost 100% of us are going to need long-term care at some point. So,
That's exactly.
well, thanks, Vicki.
Good idea. With that, I want to thank everybody's time. Thank you to Argosy University for hosting this event. Thank you to ETV. for recording this event, and thank you to the panelists for your time and expertise. Thank you very much.